Good morning. Today, it's my very pleasant duty to introduce the plenary speaker today. Actually, I've been given a paper, but I don't need that to introduce Professor Anuradha Asanaka, who is a professor in pharmacology in the department in pharmacology in Ragama, and he's more in the medicine department with us. So he will talk about NAFL, the role of the physician. He has been doing research in NAFL for more than 20 years, and he has more than 60 publications and presented more than 100 abstracts in this topic, most of them in this topic. So I hand you over to him. Thank you.
Thank you very much, Chairman Sir, for kind words of introduction. Good morning, ladies and gentlemen. First, I would like to thank the President and the Council of the Ceylon College of Internal Medicine for inviting me to give this talk on a topic which is very close to my heart. So what I'm going to do this morning over next 30 minutes is to discuss a case scenario and then ask you a few questions and answer those questions at the end. This is a patient presented about 5 years ago, a 55-year-old man on long-term treatment by a clinician for type 2 diabetes, complained of loss of weight for 6 months. The clinician attributed the weight loss to metformin. The patient had a strong family history of cirrhosis. The patient's siblings, including 2 medical consultants, wanted a second opinion and later the patient was diagnosed to have a multifocal HCC with cirrhosis, and the patient succumbed to the illness 2 months later. So my first question is, could this have been avoided? Then the second question is, what's the nexus between type 2 diabetes, NAFLD, NASH, cirrhosis, and liver cancer? Third question is, can we intervene before these patients end up with end-stage liver disease or untreatable liver cancer? And the fourth question is, how can we prevent or delay advanced liver disease and liver cancer in patients with type 2 diabetes? So are diabetics routinely screened for fatty liver? The answer is not yet, but fortunately things are beginning to change. But all patients with diabetes are very well screened for other macro and microvascular complications, as you are aware. So is NAFL the neglected complication of diabetes? The answer is probably yes. So who are the clinicians looking after these patients with diabetes and fatty liver? Still mostly general practitioners and the physicians in internal medicine, the endocrinologists, and sometimes even by cardiologists. If you take fatty liver and diabetes, 10% of the world population has diabetes and 30% of the world population has NAFL. So there are about 20% of NAFL patients without diabetes. And about 70% of all diabetics have fatty liver, and this figure reaches 100%, near 100% in patients with long-term diabetes and who are obese. And if you take the NAFL patients, nearly 50% of them have either diabetes or impaired glucose tolerance. But the last line is the worst line for you to hear. 15% of patients with fatty liver and diabetes have advanced fibrosis. So this is alarming because they are going to develop end-stage liver failure within next 10 to 15 years. So when you see a patient with diabetes and fatty liver, you have to always keep that in mind, that this patient could be already having advanced fibrosis. So this is the paper by Kenneth Kusy, published this year in Diabetic Care, saying that more than 15% of the patients with diabetes already have advanced fibrosis at the diagnosis. So we published this paper many years ago from our Agama Health study, and it showed that patients with fatty liver who did not have diabetes at the diagnosis develop diabetes more frequently than that of a normal population. And we published 10 years ago, and this immediately got this response from a great researcher in fatty liver, Professor Yonosi from US, and he uploaded this finding and he wanted to use this to prevent diabetes in patients who with NAFLD who didn't have diabetes at the beginning, but probably we have not used this opportunity to use it as a method of primary prevention for diabetes. So what's the relationship between fatty liver and diabetes? The risk factors are the same. The interventions like dietary interventions and the lifestyle modifications are the same. And some diabetic drugs, and most of the diabetic drugs are effective in NASH. And are they different manifestation of a same illness, or are they different sides of a same illness? Or is type 2 diabetes a liver disease? Some great liver physicians think that type 2 diabetes is primarily a liver disease. So what triggers NAFLD? So many things like genetics and the gut microbiome changes, but the primary trigger is high carbohydrate intake and saturated fat intake resulting in fat accumulation in the liver. Liver fat, which is a form of ectopic fat, leads to hepatic insulin resistance and a state of systemic inflammation leading to high cardiovascular mortality. So when you develop, if you have a patient with fatty liver and when the patient develops diabetes is one of the promoters of advanced liver disease leading to cirrhosis and liver cancer. And a patient with type 2 diabetes has fatty liver, it worsens the insulin resistance, increase the risk of cardiovascular mortality, and his diabetes become very difficult to be managed. So few points for you all to remember. NASH cirrhosis and hepatocellular carcinoma incidence is going to rise alarmingly. It's going to be a tsunami within next year, 10 years, and there's no solution, easy solution in sight. And liver cancer almost always develop in the background of cirrhosis. And even here, the number one cause of mortality is cardiovascular disease, not cirrhosis. Cirrhosis due to NASH is metabolically very different from other forms of cirrhosis like alcoholic cirrhosis, because their diabetes is very difficult to be controlled. They already have CKD, they have ischemic heart disease, and they are obese. So they are very difficult liver transplant candidates. So diabetologists were not recommending for screening of fatty liver in these patients like they screen for nephropathy and retinopathy, but things started to change about 2 years ago with these papers. And 2019, for the first time, American Diabetes Association recommended screening for all diabetes with ultrasound scan and for advanced fibrosis with non-invasive measurements of fibrosis. I will come to that later. And then this year, the European Association for Study of Diabetes recommended the same. So what is FIB4 score? FIB4 score is a non-invasive method of detecting fibrosis using 4 parameters. And now FIB4 score is recommended for all diabetics to be performed every year. And because it is only recommended every 2 to 3 years in other forms of fatty liver, but in diabetes, because of the high risk of fibrosis, FIB4 score is recommended every year in all patients with fatty liver and diabetes. So this is the FIB4 score. It's a very simple score using the age, the AST, the platelet counts, and the ALT. It's available as a free app online. You can immediately calculate it at the bedside. And just be familiar with this, because when the FIB4 rises, it increases the risk of fibrosis. The age, the AST, you should be familiar with the AST-ALT ratio. when the AST starts going up and the ALT starts dropping, then FIB4 rises, and it says that it's going to increase the risk of fibrosis. And these are very sensitive, and make sure that you do these tests from a reputed lab, and there are no other causes for AST elevation like myositis or hemolysis like thalassemia. And if there is no ITP to reduce the platelets, this score is absolutely sensitive in detecting early fibrosis. So I will give you two examples. This is a young man, 30, with an AST of 40 and ALT of 80 with normal platelets. When you calculate the FIB4 score, it's 0.56. It's way below 1.3, which is the cutoff. And for this patient, no diabetes, you repeat the non-invasive markers in 2 to 3 years' time. So see what happened to the AST, ALT, see the ratio. The gap has narrowed significantly from 40 to just 5, and the age has gone up to 55. Platelets have dropped slightly, but to the naked eye, you will not detect that there is significant fibrosis. Just put the FIB4 score in place and check and see the FIB4 is 2.17. It's way above 1.3, and this patient needs a fibroscan. This is a fibroscan, and it's like ultrasound scan, very user friendly. Use this probe, and you should be familiar with these reports. The 204 is the CAP score, and 3.5 is the liver stiffness measurement in kilopascals. There on the right hand side, the liver stiffness has gone up to 33. This is cirrhosis, and the 3.5 is normal. So here, these are the cutoffs, usual cutoffs, but now this is normal. 2.5 is the normal. You expect that in a young child, lean child, but less than 8 nowadays is taken as the cutoff for advanced or significant fibrosis. When it goes beyond 12.5, then it is cirrhosis, and in a patient dying of cirrhosis, you expect it to be 70s, 80s. So this, from each step to the next step, it takes years. This won't happen overnight. So if you have 2.5 at the age of 5, you expect 7 at maybe 20, then it starts fibrosing, and you can end up with cirrhosis around 45, 50, 55. So, and when it is more than 12.5, you have to start them for surveillance for hepatocellular carcinoma and varices. So what should be the responsibility of the physician? So we have to make sure that our not internal medicine colleagues be aware that liver is equally or more important than most of the organs that are being screened by diabetics up to now. We have to understand that the degree of ALT elevation or degree of fatty liver on ultrasonography like grade 1, grade 2, grade 3 is not going to predict significant fibrosis. You have to go for non-invasive tests like the FIB4 score or the fibroscan, and we have to be familiar with the cutoffs of significant fibrosis like FIB4 of 1.3 or LSM of liver stiffness measurement of more than 8. And we have to be aware of referral pathways for further care. When if LSM is more than 8, you have to refer to the liver physician for maybe a biopsy and to start liver-directed therapy. You have to be aware of the fact that though lifestyle changes are the mainstay, some diabetes drugs and statins have beneficial effects on the liver. So diabetes medicines beneficial in liver. So these are diabetics medicines that are known to be beneficial in RCTs. Pioglitazone, the GLP-1 agonists like liraglutide, semaglutide, I will talk about them in detail. Then SGLT2 inhibitors, we heard a lot about them yesterday morning. Then saroglitazar, which is approved in India. And physicians should encourage their colleagues to use these drugs for these patients with diabetes plus fatty liver. And liver-directed therapy is only for patients with advanced fibrosis, that is vitamin E and obeticholic acid, and ursodeoxycholic acid has no place in the treatment of non-alcoholic steatohepatitis. So this is a study by Kenneth Kusi again on long-term pioglitazone. So it's a drug which was used in the past but went out of fashion due to various adverse effects. But now we know that it's a good drug and it's making a strong comeback for this indication. It's relatively harmless unless you have heart failure. So it's a PPAR agonist and it's an insulin sensitizer with some lipid lowering activity, and it's making a strong comeback because most of the concerns have been sorted out. Liraglutide, which is GLP-1 agonist, it reduces weight, it reduces appetite, and it's a good drug for obese patients with diabetes. In the small randomized controlled trial, it's been shown to be beneficial in non-alcoholic steatohepatitis. Then semaglutide, this is the study this year, and again it's very beneficial. In fact, semaglutide was approved for weight loss by the FDA this year. Then saroglitazide, something like pioglitazone, a diabetic drug and a lipid lowering drug, and it's approved for the first time in India. So it's the first drug to be approved anywhere in the world for this indication of non-alcoholic steatohepatitis. Still not available in our country, but no other country has approved it, but we have to wait and see what the other countries are going to do with saroglitazide. Then SGLT2 inhibitors, beneficial in heart failure, beneficial in kidney, and beneficial in fatty liver as well, but we still do not know whether it's due to the fact that it reduces weight. But strong evidence to say that even this meta-analysis say that even SGLT2 inhibitors are beneficial in patients with fatty liver, NASH, and diabetes. Then coming back to statins, so we have a lot of problems using statin in patients with elevated liver enzymes. Is it true? No, it's not true. This is a paper published in the Journal of Hepatology on use of statins in cirrhosis. So if people can use statins in cirrhosis, why not we use it in patients with fatty liver? So these are the statins and its benefits. So theoretically, statins are beneficial in liver disease. In animal studies, it has been shown to be beneficial. Observational studies, very beneficial. Small randomized control trials shown to be beneficial, but large randomized control studies are pending. And it reduces inflammation, reduces fibrosis, reduces portal hypertension, greatly reduces the incidence of hepatocellular carcinoma, and above all safeguards the coronaries for a transplant, because transplant takes 10 hours, and we need good heart to tolerate a transplant. And lipophilic statins are better, that is simvastatin and atorvastatin, which are kind of concentrated in the liver, is better for its liver effects. So these are the effects of statins, and angiogenesis, and reduce inflammation, and reduce fibrosis. The pleiotropic effects of statins, these are beneficial in fatty liver or non-alcoholic steatohepatitis. So statins and the role of the physician, still a lot of doctors are reluctant to use statins in patients who have elevated liver enzymes. So I think we should encourage, we should realize that, understand it, study it, and encourage others to use statin in these patients, because these drugs may be life-saving in these patients. I told you it's the coronary risk which is the highest and the main cause of death in these people. So we should encourage them to use statins in these patients for their hyperlipidemias. So the American Diabetic Association, American Heart Association, and American College of Cardiology last 2020 recommended use of statins for all diabetes patients between 40 to 75, irrespective of the cardiovascular risk. So you can easily use this to treat these patients with diabetes and fatty liver because benefits are enormous. So this algorithm for diabetes patients, If you take a diabetes patient, you have to screen them for liver fat by ultrasound scan. Then if there is fat, evaluate clinically with non-invasive methods like the FIB4 score. And then if FIB4 positive, go for the fibroscan. And if fibroscan shows LSM of more than 8 kilopascal, refer for hepatology. If there's no advanced fibrosis by fibroscan, repeat the FIB4 score at 1 year. And this is an algorithm published this year. For all patients with fatty liver, they have to undergo lifestyle modifications like physical activity. I am sure you are aware of this, 150 to 200 minutes of aerobic exercise for a week. Then Mediterranean diet or DASH diet. I am sure you are familiar with the DASH diet for hypertension. Then limit saturated fats, red meat and processed meat, refined carbs and sugar sweetened beverages like colas. If they have dyslipidemia, consider a statin. A lipophilic statin is better, like simvastatin or atorvastatin. If they have hypertension, ACE inhibitor or angiotensin receptor blocker because of possible antifibrotic effects on the liver. Stop tobacco. If they are type 2 diabetics, consider GLP-1 agonist. Liraglutide is available in our country. SGLT2 inhibitors available in our country. Pioglitazone available if there's no heart failure. If they are obese, 10% weight reduction, hypocaloric diet, pharmacotherapy, and bariatric surgery. So to conclude with the clinical scenario, I think I have given answers to most of the questions that I brought up at the beginning. So this happened 5 years ago. So could this have been prevented? Answer is, if the current guidelines were in place, I feel this could have been prevented. So this is a guideline by the American Gastro Society, American Gastroenterology Association. It says that patients with non-alcoholic fatty liver disease with non-invasive markers showing evidence of advanced fibrosis, that's before the onset of cirrhosis, should be considered for hepatocellular carcinoma screening. So I think if the patient shows advanced fibrosis, even before the onset of cirrhosis, they should undergo screening for hepatocellular carcinoma, because that is the number one killer in cirrhosis. So to summarize, Chairman Sir, ladies and gentlemen, cirrhosis due to NASH is rising alarmingly, and we are not ready to deal with that. And cirrhosis itself is difficult because by the time they develop cirrhosis, they have coronary artery disease, they have very difficult to control diabetes, they have CKD, and they are obese, and they are very difficult transplant candidates thereafter. So clear guidelines are in place for diabetes caregivers on the screening of NAFLD and referral pathways. Patients with advanced fibrosis detected by non-invasive methods should be referred to the hepatologist for confirmation and for liver-directed therapy. Physicians should be familiar with the latest developments in the field of NAFLD like FIB4 score and FibroScan. For the moment, we have only 2 fibroscanners for the entire country, one in the private sector and one in Ragam. I think others should encourage their purchasing officers for invest on this, because it's going to be very critical for the management of patients with fatty liver. Help other diabetes caregivers to be familiar with the ABC of NAFLD, especially general practitioners, and a lot of patients are under general practitioners for their diabetes without knowing that they have fatty liver. Be aware of the fact that though lifestyle changes are the mainstay, some diabetes drugs and statins have major beneficial effects on the liver. marker එක වැඩ කරා. All right, okay. So before I wind up, the picture that I show you always, these are migratory birds. Just before their departure back home, they start feeding profusely till their bellies are become fat with large livers, which are 10 times larger as their normal livers, and then they fly back home 8 to 10 days non-stop over 8 to 10,000 kilometers. So uh, what can we gain from this? You can get, the lesson is that you can get a fatty liver quickly, and you can get rid of the fatty liver equally quickly, at least in birds. Thank you very much for your kind attention.
Yeah, thank you, Professor Anuradha, for that excellent talk. Normally, we don't allow questions at a plenary, but I think this is such a good topic, and we have actually such an expert on this. We can allow a few questions till we have a few minutes here.
Thank you for the excellent talk, sir. Just like in dengue, we have forgotten the liver. I think diabetes, we don't think much about the, again, liver. The last slide shows the everything importance of the fasting also, I believe. So you didn't touch much about the fasting in case of fatty liver. I'm sure that there should be a place. Other comment is now, when it comes to diabetes, obesity, or fatty liver, the underlying problem is insulin resistance, which is there for several years before this turn out to be a diabetes or fatty liver. And as you said, it is probably the processed carbohydrate, then the high insulin for several years. The insulin itself can cause insulin resistance. Then, of course, all the disease, including the Alzheimer's disease, diabetes, obesity, fatty liver, everything comes due to insulin resistance. So that is my comment, but I would like to know about the fasting also. I'm sure fasting should play an important role when it comes to fatty liver.
Thank you very much, Sundaresan. I agree with you, but still we don't have studies. What do you think, Arjuna? We don't have studies to suggest that these various fasting regimes are beneficial in non-alcoholic steatohepatitis. All calorie reductions, right? How you do the calorie reduction, I really do not know whether it applies to those methods of 16 to 8 or intermittent fasting or whatever, but calorie reduction will lead to improvement. What is necessary is weight loss. If you lose your weight by 10%, it's beneficial. Doesn't matter how you do that, whether it's by bariatric surgery or whether by fasting methods. It doesn't really matter. If you lose 10%, in fact, the fibrosis reverses. I hope you agree, Chairman.
My mind now, is there a place for metformin? Metformin reduces weight in general, but have there been any studies with metformin, especially at the NAFL stage, whether metformin could be of any use in preventing the complications of diabetic-related liver disease?
Thank you. Again, a very good question. So, metformin has not proven to be beneficial in non-alcoholic steatohepatitis in RCTs. But other drugs like liraglutide, saroglitazar, pioglitazone, vitamin E, obeticholic acid, they have been shown to be beneficial. But in observational studies, large observational studies, including 10,000, 20,000 patients, in patients who develop cirrhosis, their HCC risk is low when they have been on metformin. So what is said is, someone is on metformin, please continue that, because it's going to reduce their complications when they get cirrhosis. So if someone is on metformin, a cirrhotic patient is on metformin, please do not stop metformin, because it has been very clearly shown that in cirrhotics it's beneficial, at least the hepatocellular carcinoma risk, which is the number one risk. Yeah.
Okay. Professor Anuradha, Thank you very much. So, Krishanti.
Yeah,
Yeah,
Krishanti,
and
yes.
now, is there a place for statins irrespective of cholesterol levels in diabetes?
So that's what
Diabetic liver disease.
yes, because same answer, Krishanta. The patients who have been on statins for various other reasons, their hepatocellular carcinoma risk is much lower. Their portal hypertension is much lower. Only thing is we don't have RCTs, but theoretically it's beneficial. Large cohort observational studies have been shown to be beneficial. There are enough studies to say that, but still RCTs are going on. So without RCTs, no one is going to recommend, put it in on paper in a guideline. But because what I said was that because now we can use statins without a fear in a patient with diabetes according to latest guidelines. So if the patient has, whether it's liver disease or fatty liver or any other illness, if the statin is indicated, please continue statin irrespective of their SGPT levels or whether they have cirrhosis or not, because there's large RCT ongoing in Europe in decompensated cirrhosis patients with simvastatin and rifaximin combination. Rifaximin for the gut microbiome, simvastatin for the liver inflammation and reduction of portal hypertension, reduction of angiogenesis, prevention of hepatocellular carcinoma. That's ongoing. That will give us the answer, and probably after that it will come into guidelines.
In the interest of time, we'll conclude the questions at the moment. So on behalf of Sri Lanka College of Internal Medicine, I thank Professor Anuradha Dasanayake for delivering that excellent and timely lecture. And may I invite my co-chair, Professor Arjuna De Silva, to present the token of appreciation.